welcome to the Make an Impact podcast presented by the American Association of Suicidology. I'm Chris Cosentino, and today we're joined by Dr. Paul Quinnett. Dr. Quinnett has been a clinical psychologist and trainer for more than 35 years and is the executive chairman of the QPR Institute. Dr. Quinnett, welcome to the podcast.
Well, thank you, Chris. Glad to be here.
Now, before we jump into QPR Institute and training, our listeners would love to learn more about you, what inspired you to get involved in suicide prevention, and ultimately make an impact as a psychologist.
Well, I think it goes back to my immediate postgraduate years after I got a PhD in clinical psychology, as I went to work in a state hospital as an intern and then later as an employee for a couple of years. And during that time, I lost two of my supervisors to suicide. One was a psychiatrist, really intelligent, brilliant man, was dependent on alcohol and maybe other things. I don't know, but he took his life. Shortly after I left that job, I heard about it. His was my first funeral in my life. And then later I learned that my clinical supervisor on my internship program, a brilliant social worker, she took her life. And so right out of the box, out of graduate school and out of my internship training, I had experienced the loss of two people who were close to me, had influenced my life and my career, provided wonderful supervision for my startup. And then when I went to work finally at a mental health center, a brand new mental health center, we got a federal grant and began a big public health mental health center. We lost a patient to suicide early on at that agency, and subsequently, year after year, we lost patients who were either active with us or had recently been discharged from service or had been seen by my emergency services staff and were found to be not suicidal enough to go to the hospital, who then later killed themselves. And these were, in my view, treatment errors of some kind, that we had failed to properly assess the risk, and someone died. So this was on my watch, and I had been impacted, therefore, by people that my clinical services were trying to help, and also two of my recent supervisors. So I was part of my job within a year of my going to work at a mental health center was to take over the crisis line. We had a 24/7 crisis line for our county and the region, and I became the director of that, and so became responsible for the training of the students and volunteers who we used as staff. And we had no training curriculum that made any sense, really, compared to what there might have been out there. It was the Wild West in those days. And over the years, I realized that there was poor training for. I also became, I should add, the director of an APA-approved clinical internship for the American Psychological Association. And we took 4 interns a year into our by then it was a large mental health center. And we trained them. And I noticed that every single student we got came in from an APA program someplace, and they came with no training in suicide risk detection, assessment, management, or treatment. None. They said they were told, you'll learn how to do this on your internship. Well, we were that internship. So eventually, after multiple losses of patients to suicide in our agency, I helped start a survivors of suicide group in our county, which met at the Red Cross. And I provided technical support and kind of clinical support to that program. So I got to see the consequences of suicide from the other side, from the family side, the survivor side. And I just realized that some of the people in our support group had lost their sons or daughters to us while they were in treatment with us. So this was a full revelation about what we weren't doing well enough, which was providing suicide-specific care, at least the detection of risk and the assessment of risk. And so I said, I don't want to take too much time here, but I set up a study group and asked my 4 psychology interns to review every single death in our mental health population over, I don't know, 15 years, 20 years, and correlate those deaths. Were they by suicide or natural causes? And then work with the coroner's department in our county to establish the cause of death for those people that we'd had contact with. And lo and behold, throughout our county of 500,000 people, we had touched the lives of many of those who had died by suicide. We'd seen them in our care. We'd seen them in emergency services situations, the hospital ER. I had a 25-person team covering the county for mental health emergencies. So I got this insight into what was happening from a systems point of view. And then I put together an A team to create a curriculum to train clinical providers in these evidence-based approaches when there were very few back in 1990s. But we tried to improve and enhance our clinical care, set up routine screens, routines assessments, management of risk over time, and those kind of things. So we created a suicide risk reduction program within our mental health center, which went on to win a national award for avoiding suicide malpractice from the Mental Health America group back then. And the American Psychiatric Association Patient Safety Committee featured us as a best practice for client safety, patient safety. And I made a presentation to the APA on that regard. But anyway, so that's how I got interested. And I personally then began to see patients at risk of suicide. And that was my clinical practice, both at the mental health center, where I kept 4 hours for clinical care for myself every week. And then I had a private practice as well. And my private practice became the referral source for a lot of people in our community who were frightened by suicidal patients and would refer them to me because I'd written a book by then about the subject. So that made me an expert. And pretty soon my clinical practice and private practice was pretty much people at risk of suicide thinking about killing themselves. So that's how I got into it, wrote a book, went to my first AAS meeting back in the late 80s, I believe. And that's it. That's how I got in.
Yeah, I mean, the QPR Institute became an independent organization in July of 1999 and is a longtime partner of AAS. Take us through the history and the mission of the QPR Institute.
Well, very briefly, if I can, we started doing the work of the gatekeeper training far back before QPR was founded in 1978. We began a community outreach program for frail, at-risk elders who ended up in our hospitals and our nursing homes too soon, went to the state hospital oftentimes because of their psychiatric illness, and they were literally dying in their homes in our community because no one was there to care for them or oversee them or support them. And so we developed an outreach program for at-risk elders. And part of that at-risk effort was to screen them for potential suicide risk. And lo and behold, we found literally thousands of people at risk, and many of them were having suicidal thoughts or said goodbye to us in their visits and so forth. So we initiated this outreach program, which won the Kennedy Award for innovations in psychiatry and government service back in the day. But what we noticed was over time, the suicide rate among people over age 65 went down in our county compared to other counties in the state of Washington. It went down, stayed down, and it has stayed down, comparatively speaking, for all these years since the late 80s when we really got the program working. And QPR grew out of that. That said, we had screening questions. We said, this was one of my programs, and I had a guy named Ray Roshko, a social worker, who was the champion of that program and finally became its director. But at any rate, the Q in QPR came out of you got to question people whether they're having thoughts of suicide. If their symptoms are there and they're having a major crisis and can't seem to survive their circumstances, then we need to ask them if they're thinking about self-destruction. That's how that got started. And I was assigned to the public health department in our county to work on suicide prevention as a preventable injury under the public health rubric. And so I became a consultant too, and I helped write some of the early policies. And then I wrote the QPR program in that context, working with public health officials. And we instituted it in very small ways in our county, and we began to build a curriculum for how do you do this? How do you train people to teach this? And so some of our first QPR instructors were public health educators who went out in the field and taught this with what was then a pretty rudimentary program, in an hour, which we found through our research, we could only get an hour at jails and nursing homes or hospitals, places like that. They'd only give you an hour. Nobody wanted to hear about suicide prevention. So it was pretty challenging in the early days to get a venue and to get a yes, let alone charge for it. So that's how we got started, and that's how I ended up probably going to my first AAS meeting. We got a grant, by the way. We got when I presented the program to the Eli Lilly company, who did public funding for some innovative projects, and they actually Eli Lilly gave us $50,000 unrestricted grant to develop a video to describe the program, and so that was probably the first real investment in that in QPR was from that company, and we got we asked Carrie Fisher to host the video. So Carrie Fisher agreed to do it. She'd had her own issues with mental health, and she was wonderful and did the video, and that became a very popular video. I think it's still around. But people used to ask me, how do we get Princess Leia to do the video with QPR? And I said, well, if you have to ask that question, you don't understand the Force.
That's great. What now? Let's dive into it. What does QPR stand for? And walk us through it. Walk us through the training.
Essentially, QPR, the Q is the question. And now it's very popular. It's all over the planet now that you have to ask about suicide. The reason is that people who are thinking about taking their own lives feel stigma, self-imposed shame, self-imposed, all of this and publicly supported. People are fearful of anybody who wants to take their life. So there's an agreement to avoid the subject. So the first thing you have to do if you're suspicious that someone might be thinking about ending their life is to ask them. Just ask them. And I've written about this extensively. It's enormously difficult to ask this question. It takes a great deal of courage because if they say yes, you now have a burden of care for that person that you didn't have a minute ago. So, and we had been training under a federal grant, but not training people in suicide risk assessment and depression treatment and that sort of thing. And we found again and again and again that students couldn't ask this question, that the words would actually stick in their throat, even though they had just been shown under role play how to do it, how to ask this question. They simply couldn't do it. And the reason was fear. There's fear both ways. And so people tacitly agree not to talk about suicide, even though it's the elephant in the room. And so the more I realized that was key to unlocking this interaction that can be life saving was that you had to teach people to ask this question, and you had to teach them how to do it explicitly, including in a role play, which we do in the training, as everybody gets a chance to practice this intervention, this first part. And then the persuasion, the P is persuading someone to get help, some kind of help, professional help from an elder, help from somebody. And so that comes through the usual things, active listening, don't pass judgment, stay quiet, let them talk, let the problem bubble forward. And I encourage their talking about this until they can begin to see some light. And so that persuasion it's all detailed in our training and in our booklets and in our publications. But that's the part where you get the person to take action with you, supported by you, taken by you, to by the hand if necessary, to a care provider or a priest or someone who can help. And then the R is the referral part, which is the hardest part of QPR because our mental health resources are so limited and unavailable and inaccessible and barrier ridden from one end of the country to the other. So that's why we've created a new program. We'll talk about that right now. But at any rate, that's the element, the CPR equivalent. And we actually copy the QPR concept, awareness, recognition of crisis symptoms, early intervention, early relief, and early referral. Those are the same four steps. And we took a public health approach. This had to be low cost, had to be population based. It should be saturation training. The more people trained in CPR per capita, the more lives are saved each year by this bystander rescue. So there's I have studied the CPR research extensively, and so surveillance. I'm a retired, long since retired Army veteran, and I worked in the Army Security Agency, which is now the NSA, in the surveillance, signal surveillance, that kind of stuff, signal intel. And this is really with the same problem. People are having a crisis in the public. Someone in their social network needs to be able to recognize symptoms of distress and respond quickly and boldly to those symptoms.
When we talk about QPR, have there been any adjustments to the way the training has been conducted over the years? And if so, what changes have been made? And I'm curious to see it, or has it been, hey, we built it on day one and it's been the same ever since?
It's not really been the same. The acronym has stayed the same for lots of reasons. But we have a research to practice model around here, which is if we have new research that suggests a better way to do something, we adopt that research, and that's what we do. For example, Wendy Cross at University of Rochester and her colleagues did a study showing that the role play, because lots of times people don't want any more than an hour of training. They may need more, but they don't want more. So the question was, can you do a role play after you deliver the content of the required curriculum? And the answer is yes, you can, but it takes an extra half hour to an hour to do that, depending on how many people. And we limit the training to 35 people in a group. So, but Wendy's research showed that in fact the role plays enhanced and improved the retention of scores in self-efficacy and knowledge and attitude, and it had a beneficial effect on the training. It's dose effective, so it was like another half-hour dose added this much to the training, the power of the training to be recalled and be able to execute the steps of the intervention, in the follow-up at 6 months and so forth. So we then developed all these role plays across all kinds of occupations and professions and settings and age groups. And those are now included in the training, depending on what group you're teaching. I'm just finishing up right now, in fact, the role plays for police officer to police officer. Your partner's in crisis. How do you use QPR to intervene? So we set up the role play scenarios, the crises, the risk elements, and all of that, and teach people how to do the intervention and make sure that certain things happen in terms of safety, like means reduction and so forth. So that was one example. We included role plays now, including in our online interactive QPR training, which is delivered entirely online, has role plays in the training. So you get to learn something and then apply that something to a real world situation and get immediate feedback on how you did and so forth. Second thing was, um, let's see what, quickly, the second thing was the reinforcement. We found that if we provided a online emailed practice session, a role play rehearsal, real world rehearsal by email to people after the training. Within 6 months after the training, they get a refresher course. So it's not one-off training now. It's training plus a refresher. With that refresher session, this was independent research, by the way. We didn't do this. We had other people who could have better funding than we do for this. But that 15-minute research or practice session produced much stronger results in terms of the desired outcomes. Question one, did people who got the booster session identify more people at risk of suicide subsequent to the practice session than those who didn't get the thing? And that was true. Number one, they found more people at risk. That means their surveillance was better, their eyeballs were sharper, their ears were working better. Who knows? And second, they accompanied those referrals to someone who could help, like to a school counselor. Might have been a teacher in the study or someone else, but they identified more people and they also got them referred and accompanied that referral. So that referral net circle was closed. So we now subsequently, we offer what's called QPR Refresh, which are online recertification booster sessions, and you get some review of your course, basic course review, and then you get practice sessions, two of them in that dose. Comes to you by email, boom, boom, boom. You review and rehearse, get recertified, take your quiz, practice twice, and you're done. And that we believe is honoring the research that was done to show that these booster sessions enhance gatekeeper effectiveness at the point of service.
Now, the QPR Institute conducts both online and in person trainings for both individuals and organizations. Who is your target audience for the training?
Our target audience is pretty much anyone who wants to learn to save a life. We don't segment the market in the sense of have targets. We respond to everybody and anybody who wants to reduce the risk of suicide in their population, whether it's a church or a business or a school or a university. We have lots and lots and lots of universities as customers, and we have lots of school districts. The entire school system in Hawaii uses this program and is testing for us now the recertification annual training with the role plays with really great results from the users. So our customers are states, mental health systems. Guys, we're in 32 countries now. I couldn't even begin to name all the businesses, including some, Fortune 500 companies use the program. So we tried to make it as universally acceptable as we can, both language and culture wise. So QPR has been translated into like 20, I think somewhere around 20 languages. We just started QPR in Turkey. Uh, we're a-religious, we're agnostic, so we get endorsed by Mormon bishops and imams and everybody in between. So we're happy about our cultural adaptation capacities, which we aimed for early in the going.
That's wonderful. Yeah, I mean, I personally, yeah, I personally completed my QPR training a few months back with Fonda Bryant, which was wonderful. And everyone else I have spoken with about QPR training absolutely raved about it. What impact have you seen since you started the training?
Well, I'd like to report that the results are outstanding and the rates are coming down and being mitigated and, fewer attempts are being made, but that'd be dishonest.
Mhm.
I'm not sure we've moved the needle. We ask ourselves that all the time. We've trained over 6 million people, and we're not sure it's made any substantial impact on the rates. Do we have anecdotal stories? Thousands of how many people have been, uh, you know, saved, as it were, by this intervention in a timely fashion. We have hundreds of those kinds of stories, but they're not real data. The only real data we have is from one study was done some years ago, actually, Walrathanol, and they found that counties that had received gatekeeper training, which was both, assist and QPR and whatever else, had lower rates of youth suicide events than did counties that didn't get the training. But other than that study, I've not seen anything showing anything but training effects. And to be honest, if you get a great training and you feel really good about it, and you learn a lot and you give it a high rating, doesn't mean that you're actually going to be able to carry out the intervention you were taught. This has been true in CPR training as well. Within just a few months, I think it's over half the people who've had CPR training no longer feel competent to carry out the intervention. And they'll stand back while others who do feel competent start the intervention with somebody who may be having a cardiac event. So though we have better data now, we're just now getting data on follow up from some large districts, school districts that have been implementing QPR for several years now, and we do have some data which someone I wish would take off our hands and analyze for us, showing the positive impact of referrals to treatment providers. We think that ought to be a life-saving link. You identify someone who's having suicidal ideation and getting no help, you get them competent help. They should then be a plus on the side of suicide prevention, that they got help they needed and they got into recovery, got their life restarted, and so forth. And at which time suicide ideation becomes an interesting journey in life, but not the end of it, certainly. So we want to see this data analyzed on a much larger scale than it's ever been before, and we also want to see the impact of treatments. We're strongly behind evidence-based treatments for suicide risk and suicide-specific care. We want to see people get suicide-specific care. I have a granddaughter who just finished her PhD in clinical psychology and child psychology, and she's in the field now working, and she reports to me that so many of the providers she meets in the community at the master's level and even PhD level are untrained. They remain untrained and are terrified when they get a suicidal patient, as it were. And yet here working in youth, 1 in 4 youth is going to have had suicidal ideation in the last year, at least the last report I saw. So if a fourth of your incoming clients are going to be at risk of suicide and you don't know how to talk to them, we have a real problem here. So, so when I say we get referrals made, it doesn't mean they're made to competent people. That's the frightening thing for me. AAS issued a white paper on this, partly at my instigation, because I wrote a nasty email to the listserv about our failure to recognize our own competence and
Yeah.
get people better trained in how to help folks at risk of suicide.
I mean, you mentioned you're doing trainings in more than 30 countries around the world. Are there countries that are doing things better than others? And are there things we can take from other countries and about the way suicide is being addressed in the US?
Well, guys, that's a question for people at a higher pay grade than me. I, I really don't know. I know we have been working with a group in India for 5 years now,
Mhm.
and we have a project starting up right now in Andhra Pradesh, in the state of Andhra Pradesh, and there they have the endor. This is a QPR based intervention. We're going to be using a number of our courses that target different groups and professions, but it's the kind of thing I'd like to see done in our own country, which is a state led, government down, all hands in, every school signed in, every medical student in Andhra Pradesh is going to get QPR training. That's on the table. It's going to be done. So they will at least get that in medical school. And we don't have anything like that here. Whether this all turns out makes any difference, I don't know. But they have no less pain to the loss of their youth to suicide than anyone else does. But they decided to roll this whole thing up, and the American Association of Physicians of Indian origin is one of the funding groups for this. So doctors of Indian heritage in America are helping to support and fund this project in India as a trial for the entire country. So I don't know. We can provide the training. Whether it'll have the impacts it does here and has here, I don't know. There's some cultural differences certainly, but generally speaking, it's traveled well, and our early research there is showing that it's acceptable and accessible and adequate to do what they want to try to do. So I don't know of other countries that are doing a whole lot more and innovatively, at least that I don't see it in the literature. Maybe it's there, but I'm just not seeing it.
One reason your name might be familiar to AAS supporters is because of the annual Paul G. Quinnett Lived Experience writing competition. How did the writing competition come about?
Well, briefly, I realized that one of the things we do in clinical psychology is when we want the patient's opinion, we'll cross the desk and beat it out of them. In other words, we have never been very interested in the patient's point of view. Yeah, and I say that in a kind of a joking fashion because that's entirely what the whole field is about. But when it comes to this subject, clinicians are, I think, are frightened and they're reluctant and they're uncertain about whether they should even talk about this subject with their clients. Remember, Freud wouldn't treat anybody who was suicidal. That thought it would be bad for his reputation, apparently. Uh, so we kept a muzzle on the poor clients all these years. We not wanted to hear what they think about anything, and I say that in a kind of a tongue in cheek. Of course, we want to know about it, but we don't want to know that much about it. We don't want to let them tell us everything they've experienced, including some of which I had thought would happen and has happened now with the narratives, the stories that people are writing as they're describing their relationship to providers. And some of them are wonderful and life saving, and others are pretty awful. And I expected and hoped that that might happen, as it would be a window for clinical training programs to begin to adopt some of their narratives to describe to their students what the people you're going to serve are experiencing with you and have experienced with you and people like you. And so I just thought it was information that we had long since ignored, and it was way past time to listen to these stories. And in fact, when we started QPR, a lot of our first instructors were survivors of suicide, and they wanted to know, can we tell our own stories as part of the training? And we said, yes, you can. We're trying to be mindful about how much of the story they tell and who it's impacting when they tell it. And there's some sensitivities around this, and Quincy Lazine has been written about this wonderfully. So there are ways to use that personal voice of lived experience to inform data.
Looking back on your incredible career, now your son Brian is the CEO of the QPR Institute now. You mentioned your granddaughter is studying psychology. How would you like to describe your legacy?
Oh gosh, I would. I don't know that I've thought about it. I've written a little book for inside readership on how it all got started and where it was headed and all that. But I don't know what legacy. I think is that there are 15,000 active instructors out there teaching QPR right now. They're doing the general work of suicide prevention at a grassroots level in their homes. I'm reminded of a story that came in over our networks here about 8 months ago or so. A farmer and his wife in Iowa lost their only son to suicide. Rural county in rural Iowa, where I grew up as a boy, partly, by the way, the farmer's grandson. And they learned about QPR and became instructors and still running a farm. And they became instructors to teach this to other people. And so that's what they've been doing in their little rural community in Iowa, somewhere in farm country. They are spreading hope and teaching life-saving skills and honoring their son's death by a cause that might have been preventable had they had the knowledge, information, skills to make that difference. Now, I don't know if that they could have or would have, or if that would have ever been the case. But for me, who grew up a little bit on a farm and have a great love of rural America, where the suicide rates are the highest, that's what feels good to me in terms of leaving something on the table more than I brought. And I also I live in a rural community in Idaho part of the year, and so I also work with the veterans organization there a little bit. I mean, I don't do much work with them. I support them, but they are doing all the things they are supposed to do with only a little bit of training in identifying veterans at risk living in rural parts of the Idaho mountains, getting them essential support, even food, clothing, rent support, whatever it is, to help them keep their lives together so they don't have to end them. And they're doing it on their own at the grassroots level. The government's helping them a little bit. The Department of Health from the state of Idaho is going to provide them assist training, which is wonderful. But they're doing what needs to be done, I think, at this very kitchen table matter. It's like we got to be able to talk about this as a threat to our community and our society at large. But we don't have to do nothing. We can do something. And this little thing we can learn to do is this. So if you go to Seattle and take a nap on a picnic park there, somebody's likely to try CPR on you if they think you're having a heart attack. That's how common intervention is in Seattle. So the survival rate for out of hospital cardiac arrests in Seattle is over 60%. It's less than 10 and often 4 or 5% in most counties in America, but not Seattle. Why? Because 1 in 4 adults in Seattle knows CPR. And the university there, where I used to teach, they push it as a huge public health intervention, and it saves lives every year. You know, in Norway and Sweden and some other countries, you can't graduate from high school without CPR training. So everybody in those countries knows this, and their survival rates from cardiac events in public places is very, very good. I would like to see that happen in America, where nobody can graduate from high school without knowing something about how to prevent suicide. That would be the legacy. So
That would be amazing. And you can learn more about QPR Institute by visiting qprinstitute.com. Dr. Paul Quinnett, it has been an absolute honor to chat with you today, and we appreciate all that you have done and continue to do.
thanks, Chris. Appreciate the interview.